Good morning, this is Dr. Hiba Ghanoum, lecturer of audiovestibular medicine, Helwan University, and our topic today is assessment of vestibular function. As we previously mentioned, maintaining our body balance involves three components. أول حاجة sensory input from the three systems involved, visual, vestibular, and proprioceptive systems. And then these inputs together are integrated at the level of the central nervous system, and accordingly it generates appropriate motor commands. These commands at the level of the eye movements or the musculoskeletal system. So in order to properly assess balance, we need to take a look on all three components. Patients with vestibular dysfunction or disorders report a variety of symptoms. This can include vertigo, disequilibrium, imbalance, lightheadedness, or dizziness, and many other symptoms. We need to differentiate between each of these terms in order to properly diagnose and accordingly manage the vestibular disorders. It has been agreed to use the word dizziness as a general term or a wide term to describe a variety of symptoms related to balance dysfunction. We even use it when we say assessment of a dizzy patient. So it's an imprecise term that describes a variety of symptoms. Each has a different pathophysiological mechanism and significance. Vertigo يعني sense of rotation أو sense of spinning, where upon examining the patient, as you can see in this video, we will find nystagmus. This term is used to describe the sense of being off balance while standing or walking, and sometimes the patient may even fall in a certain direction. يعني البيشنت وهو ماشي حاسس إن هو بيتطوح أو غير متزن، في عدم اتزان. The term oscillopsia is subjective illusion of visual motion. يعني الصورة مش ثابتة قدام العيان. This can either be spontaneous upon slipping of the image from the fovea أو induced by head movement. This happens in bilateral loss of the vestibulo-ocular reflex. Another term, presyncope, that the patient feels as if he's about to lose his consciousness. Feeling of faintness or impending loss of consciousness. As we agreed, we will use the term dizziness as a general term. So why does the dizzy patient act as a challenge to the physician? أول حاجة due to the overlap in symptomatology. As you have seen, there is no clear demarcating line between the various symptoms that we have just mentioned. تاني حاجة, it's very difficult for the patient to express in his own words the attacks that he's suffering from أو الابيسودز اللي بتجيله. Most of the patients هيدخل العيادة هيقول لك عندي دوخة, and then you will have to get the accurate description of his episodes of his complaint. Again, the anatomy and physiology of the vestibular system are a bit complicated, and balance function and maintaining balance includes the integration between three systems, the visual and the vestibular and somatosensory, and we have to include all three systems in our assessment. Evaluation of dizzy patients, I have three objectives: site of lesion, detect the side of lesion, and finally detect the possible etiology. أول حاجة regarding the site of lesion, we need to detect whether this is vestibular versus non-vestibular, otological versus non-otological cause. In case it is vestibular lesion, we also have to state whether it is peripheral or central pathology. Regarding the side of the vestibular lesion, we have to state whether this is a unilateral or a bilateral disease, and whether it is right or left. Finally, the possible etiology that's causing this deficit. Roadmap or steps for evaluation of a dizzy patient. It all starts by history taking. Let me tell you that the key for proper diagnosis and management of dizzy patient is history taking. It's about 70% of the work. This is followed by physical and neuro-otological examination, followed by vestibular office tests, and these will be explained in details in this lecture. And then after that we can ask for vestibular laboratory tests. Depending on the case, we might need audiological lab or radiological studies. History taking. As I mentioned, appropriate history taking is the key to reaching the proper diagnosis. So in 70% of patients, you might be able to reach the diagnosis alone by history taking. And then you confirm your diagnosis by the bedside examination, the office tests, and the other special tests. In history taking, ask the patient to أول حاجة to describe the attacks or the episodes اللي هو بيشتكي منها in his own words. What are the key points in history taking? أول حاجة, is it vertigo or not? زي ما قلنا ال overlap in symptomatology في vestibular patients بيخلي الموضوع شوية كل العيانين هيدخل يقول لك أنا عندي دوخة. You have to make sure what does he mean by the word, by the term دوخة. Is it true vertigo ولا it's not? True vertigo يعني في spinning يعني في rotation. If not, you have to decide بقى with the patient whether it's disequilibrium, whether it's lightheadedness, whether it's sense of imbalance, whether it's syncope, all the other terms that we have mentioned earlier. What about the time course of the attack? The time course of the attack is very important to reach a proper diagnosis. Time course of the attack might be seconds to minutes, minutes to hours, or hours to days. And please note that this is very important also. You have to ask the patient about if it is vertigo, you have to ask the patient about the time course of the attack of the vertigo. يعني الspinning استمر قد إيه? Because most of the patients will have or will suffer a sense of imbalance after the episode of the attack. يعني spinning might last for seconds, but following the attack the patient still has a sense of imbalance. فيجي يقول لك it lasted for hours, although the spinning itself did not last for hours. So you have to make this very clear. The time course of the attack of the spinning itself lasted for how long? Then you have to ask about the precipitating factors. زي إيه ممكن ال precipitating factors? Was it a head movement? Was it changing your position? Loud noise? The attack was following a certain diet or a certain medication. What are the accompanying symptoms during the attack? Did you experience any kind of hearing loss, sense of occlusion in the ear or ear pressure? Did you experience tinnitus, a headache, drop attack? Did you experience amplification of sounds? Sounds were louder during the attack. So these are the accompanying symptoms that we can ask for. Also, during if the patient is describing true vertigo, as I mentioned, we have to know if it's episodic, if it comes in episodes, يعني بتيجي في certain attacks. We have to know the duration of each attack كانت قد ايه, بتقعد قد ايه, the number of times اللي اتكررت فيها, حصل ال true spinning ده حصل كام مرة, وآخر مرة حصلت كان امتى, when it last occurred, and finally if there are any triggering يعني if there are any triggering events that cause attack to happen. So after the history taking, we go to the physical examination and the neuro-otological examination, and then we proceed to the what we call the bedside examination test or the vestibular office tests. Vestibular office test actually has two purposes. One is for diagnostic evaluation and the second is functional disability evaluation. The functional disability evaluation is more for rehabilitation purposes for vestibular patients, and this is not the scope of our lecture today. What we will be focusing on is the diagnostic evaluation, mainly on three levels: the oculomotor tests, the vestibulo-ocular, evaluating the vestibulo-ocular reflex, and evaluating the vestibulospinal reflex. Now we start the oculomotor tests. We are mainly searching for nystagmus. First, we have to check that the patient has a full range of movement in all planes. How do we do this? We ask the patient to follow the examiner's fingers in all planes of movement, and we check that there is normal eye movement in all planes. Then we start searching for spontaneous nystagmus. We ask the patient to fixate his vision on a certain target that is approximately 4 feet away from the patient. This target might be the examiner's finger as well. If we find nystagmus, then we have to record the amplitude and the direction, whether it's horizontal or vertical, of this nystagmus. After fixation, we have to test for spontaneous nystagmus, but without fixation, by abolishing fixation. How do we abolish the fixation? By using goggles, Frenzel goggles. Why do we abolish the fixation? Because subcortical inhibitory mechanisms are activated by the visual fixation. The vision, the ability of the patient to fixate his vision, will activate subcortical inhibitory mechanisms, and these subcortical inhibitory mechanisms will lead to inhibition of the vestibular generated spontaneous nystagmus. يعني if there might be vestibular spontaneous nystagmus, but you are not able to see this because of the visual fixation. So in case we haven't found any spontaneous nystagmus with fixation, يعني البatient شايف بالvision, then we have to ask the patient to put on the goggles and retest this patient for spontaneous nystagmus تاني ونشوف without fixation will we be able to record or to see any spontaneous nystagmus أو لا. normal result لو normal patient هيبقى no nystagmus found. In case the nystagmus is noticed, then again we have to record the direction and the amplitude of this nystagmus. The next test is the gaze test. How do we perform it? The technique is that the patient fixes his gaze at an object or the examiner's finger, 18 inches from his nose, 30 degrees to the right and 30 degrees to the left, at horizontal planes, and then we also test at vertical planes, up and down. يبقى يمين وشمال 30 degrees by the examiner's finger, and the patient has to fixate his gaze on your finger that is 30 degrees, to the right, to the left, and then on the vertical plane. Normally there will no be nystagmus. الابnormal اننا نلاقي persistent nystagmus, and please note the word persistent because you might be في حاجة اسمها endpoint nystagmus. You might find 3 or 4 beats. This is called the endpoint nystagmus. بس الابnormal ان احنا نلاقي persistent nystagmus. Another test for the oculomotor function is the tracking test, horizontal and vertical tracking, or what we call smooth pursuit. We use again the examiner's finger is located 18 inches away from the patient, and the patient is asked to track the examiner's finger that's moving in 30 degrees to the right and to the left. Normally the patient can perform a smooth tracking movement with with his eyes on the horizontal and the vertical levels. The abnormal is what we call cogwheel pattern, or we find corrective saccades or asymmetry in the movement. cogwheel يعني بنلاقي ان الموفمنت فيها كوركشن، بنلاقي الموفمنت متقطعة زي السنان بتاعة الكوجويل، فبنلاقي ان الموفمنت اكن فيها تقطيعة كده. And this signifies ايه؟ ده probably بيكون central vestibular deficit. Another test for assessing the oculomotor function is the Saccades test, the horizontal and the vertical saccades. But this time بقى we are assessing the quick movement of the quick eye movement from one target to another. Again, I'm using my fingers, or the examiner's fingers, that are located 18 inches away from the patient, and the patient is asked to follow or to focus on one target and shift to another quickly. And I'm noticing ايه اللي انا بلاحظه، movement, is it accurate او لا، is it conjugate both eyes together ولا في disconjugate eye movements. الabnormality ان انا الاقي inaccuracy, the patient is shooting away from the target، او الاقي disconjugate eye movements، او الاقي الشيفت السرعه بتاعته انها في حاجه اسمها slow saccades. كل الحاجات دي alarming signs لايه؟ كل ده زي smooth pursuit. These are alarming signs for a central vestibular deficit. Now we come to the VOR assessment, the vestibulo-ocular reflex. We previously mentioned that the VOR permits the maintenance of clear vision during head movement or rotation. طيب, how do we test for VOR? The first test is called head impulse test, وده بيعتمد على حاجة خدناها زمان في الفسيولوجي اسمها doll's eye reflex. How do we perform the head impulse test? We grasp the examiner grasps the head of the patient and flex it 30 degrees, and the patient is asked to fixate his vision on the examiner's nose. يثبت عينه on the examiner's nose, and then while his head is flexed 30 degrees, the examiner do abrupt or rapid, very small amplitude, very small movements, يعني 10 to 15 degrees to the right and to the left, and the patient is asked to fixate and keep his vision on the examiner's nose. Normally, the patient will be able to fixate his vision during the abrupt head movement. الابنورمال ان هنشوف حاجة اسمها catch-up saccades. الcatch-up saccades دي بتحصل لما the patient is not able, fails to, these are like corrective saccades, when the patient is not able to fixate his vision during head movement. And this signifies whether unilateral or bilateral vestibular deficits. This is how we perform the head impulse or the head thrust test. We inform the patient, we ask the patient to fixate his vision on the examiner's nose, and then small movements to the right and to the left, 10 to 15 degrees. The second test for the VOR function is what we call the after head shaking nystagmus, or the head shake nystagmus. The patient, the head is flexed 30 degrees forwards, and we do rapid head rotations for 30 times and then abruptly stop the movement, and the patient is wearing the Frenzel goggles, and we check for nystagmus after stopping the head movements. Normally there won't be any nystagmus. Abnormally we will find horizontal nystagmus about 3 or 4 beats to the right or to the left, and this will signify unilateral vestibular lesion. This can happen either in the acute phase or we can see it also in the uncompensated vestibular, in case of uncompensated vestibular, peripheral vestibular lesion. Positioning tests are mainly used to determine the presence of BPPV, benign paroxysmal positional vertigo, which we mentioned that is the commonest peripheral vestibular disorder. In positioning tests, actually, the movement into the position is what generates the abnormal response, not the patient being in the final resting position. And this is the difference between the positioning tests and the positional tests. The requirements of positioning tests are a reclining chair or bed and Frenzel goggles. And sometimes the nystagmus can even be seen without any Frenzel glasses. The test is similar to what's done during VNG testing, except that it lacks the recording and analysis concerning the latency, direction, and duration of the nystagmus. Anyways, we have in all cases, whether we are doing it as a bedside examination or during the VNG subtest, we have to record all three items: the latency of nystagmus. The latency means the time it takes, the time it takes for the nystagmus to appear, the direction of the nystagmus, and finally the duration of nystagmus. And we definitely have to take care in those cases with the neck or back disorders, especially during the positioning tests. وعشان كده we have several tests. The most well known منهم هو Dix Hallpike. We have حاجة تانية اسمها modified Hallpike. We have the roll test for the lateral canals. We have different tests, but the most important and very well known test منهم هو Dix Hallpike, and we'll see a video demonstrating the Dix Hallpike test. This is right Dix Hallpike, his head in the 45 degrees to the right, and then the patient lies on his back quickly with his neck extended. As you can see, هنا لابس Frenzel goggles, and you can see the torsional upbeating nystagmus, which indicates right posterior canalolithiasis. And then afterwards, the patient is asked to sit and back in the sitting position with his head برضو to the right side 45 degrees, and you can see the reversed nystagmus. Now we proceed to test of balance and posture, the vestibulospinal reflex. The first test is called the Romberg test. Romberg, patient is asked to stand with bare foot, his arms crossed, and we test him with eyes open, and then we ask him to close his eyes. Normally he can keep his balance and posture. Abnormal that this patient will experience marked sway upon closing his eyes, and sometimes even in severe cases he might take a step to avoid falling, and this signifies vestibular dysfunction. The second test is called the Fukuda stepping test. How do we perform it? The patient is asked to close his eyes and take steps in his place, march in his place for 30 to 50 steps with his eyes closed and his arms outstretched in front of him. And please avoid any auditory cues or auditory stimulation during performing this test. The test is considered abnormal if the patient shifts more than 45 degrees, and normally the patient can perform this test normally without marked angular deviation, but the abnormality is shifting to one side more than 45 degrees. Why does this happen, or what does it signify? This happens due to what we call unbalanced static activity of the two end organs What do we mean by this? Unbalanced static activity. يعني في one labyrinth is weaker than the other, and usually the patient will shift towards the weaker labyrinth. Now we'll see a video demonstrating the Fukuda stepping test. Now that we're done with history taking and then neurootological examination, which was followed by the bedside vestibular evaluation of dizzy patient, we may still need to confirm our diagnosis with some vestibular laboratory tests. What are the available and the well-known vestibular laboratory tests? أول حاجة عندنا Electronystagmography and the videonystagmography, ENG and VNG. These are the basic laboratory tests for assessing a dizzy patient, and they assess the vestibulo-ocular reflex at low ranges of movement, at low frequency ranges of movement. We'll talk a little bit more about ENG and VNG. And then we have the VEMS, the vestibular evoked myogenic potentials. VEMS are an examination of the otolith function. Rotatory chair. Rotatory chair, it assesses the vestibulo-ocular reflex, but at a higher range of movement, high frequency movements than the ENG and the VNG. And finally, one of the basic vestibular laboratory tests available is the computerized dynamic posturography. And these examine the vestibulospinal reflex, the posture and balance. As I mentioned, ENG and VNG are basic vestibular laboratory tests to evaluate the dizzy patient. The difference during ENG, I'm testing electrical potentials. ازاي? We place electrodes above and below the eyes of the patient, on the outside corner and on the forehead. What am I doing بالelectrodes دي? I'm measuring electrical potentials reflecting the direction and the velocity of the eye movements. During eye movements, I measure the electrical potentials by placing these electrodes. Whereas during VNG, مش بحط أي electrodes. I'm not using any electrodes. I'm using an infrared camera. This infrared camera بتعمل analysis لل eye movements instead of measuring electrical potentials for the eye movements. Both of them, they have the same test components. The test components, part of these test components I already performed during the bedside evaluation. Oculomotor activity, most of them were assessed during the bedside evaluation, but طبعا except for ان احنا when we are measuring whether by electrodes or by the infrared camera, and I have here the option of the analysis and recording every movement. So the first component is the oculomotor activity. I assess the smooth pursuit tracking, the saccade, gaze fixation, spontaneous nystagmus, and finally the optokinetic stimulation. In positioning tests احنا قلناهم اللي هم Dix Hallpike وزي الرول test. I'm determining whether the patient has any BPPV or not. In positional tests بقى positional tests actually are used to determine whether the vestibular system responds normally to the changes in the head and body position. يعني this is the main purpose of the positional tests, to determine how the vestibular system reacts to changes in the head position and the body position. So I check for the presence of nystagmus in different positions. I place the patient in different positions and I check for the presence of nystagmus. The 8 positions دي: head supine, upright position الأول, head supine, head left, head right, body left and body right. The fourth and the last component of the ENG and the VNG tests هو اسمه caloric testing. Caloric test is the only test that can evaluate one vestibular labyrinth, one vestibular organ at a time. ازاي؟ ان انا بعمل I do irrigation in each ear separately. I irrigate whether with water، في حاجة اسمها water caloric وفي حاجة اسمها air caloric. I can irrigate with air, I can irrigate with water, I can irrigate with a closed loop. The point is, or the purpose from caloric testing يعني is to determine the presence of أول حاجة the presence of a response in this ear is responsive and the symmetry of this response. يبقى أنا evaluating حاجتين: whether this ear will give me a response to this change in temperature، وتاني حاجة the symmetry of the response between the two ears. In water caloric and we are using أولا the change of temperature 7 degrees above and 7 degrees below the normal body temperature, and we test, and this will change the density of the endolymph and will evoke nystagmus. Upon evoking nystagmus, we measure this nystagmus and we can compare the response from the two vestibular end organs.